everybody. I'm very happy to be here and also a bit proud to be invited to your conference. And over the last days, I'm very fascinated how you're going forward with activity-based funding and taking everything beyond the hospital and things like this. And when I first came to Australia on DRG purposes, that was 14 years ago, we just decided in Germany that DRG might be a good idea for funding. And we, moreover, decided that the Our Drg system, back then it was version 4.2, would fit very well for the German needs. So we are one of those countries that, yesterday somebody mentioned that you're still selling your system abroad. Germany is one of these countries that took up your system and then put it further on. Meanwhile, we are 10 years of using DRGs in a very strict and rigid, maybe you can call it also a German way. I'm going to show you a bit how we use DRGs, but I'm very happy to talk to you on my primary focus of research. It's all about clinical quality. And one thing when I first saw something about DRGs, that was back in 1997. I was still a surgeon and working on a project with our hospital management. I was immediately fascinated. I say, wow, so many data collected on a routinely basis, that should help us improving our clinical work. But it took some time until we had the first results. And I'm very happy to show you some of the things that we do in Germany on using DRG routine data to work on quality. First of all, I want to give you a very short introduction on how we use DRGs in Germany, because it's very different than the way you do it in Australia. And then some basic ideas on quality of care, and then, of course, the most part of my talk will be about using routine data. And very often plenary talks are a bit like a helicopter view, and I decided to land the helicopter in the middle of my presentation and to walk into a hospital with you and show you how they work on their data. Well, first of all, there are big differences between Australia and Germany. First of all, in size. Here you can see that Germany would fit many, many times into Australia. So our country is much smaller than yours. Nevertheless, we have 80 million inhabitants and in the 16 states. And in terms of health insurance, 92% of our population are publicly health insured. We have a mandatory public health insurance, so nobody is allowed to be uninsured. You have to have insurance, and 92% of the population has public insurance. From historic reasons, I do not go into details, we have a lot of public insurance agencies or companies. Currently, we have still 141. We had once over 300 15 years ago, but now it's still 141 public agencies, and they receive money from wages, basically. Most of the money in our health insurance system is wage-based, and 15.5% of the gross income goes into health insurance. The employee has to pay a bit more than the employer, but basically it is shared nearly 50-50 or 60-40. And then there's a small federal contribution out of tax. It's basically meant to stabilize the insurance rate so that it not does grow too fast. We have a very high-powered hospital care in Germany, 2,045 hospitals comprising 500,000 beds, and there we treat about 18.6 million inpatients. And there are a lot of spendings, at least only for acute care. The rest is rehab and mental health. We spend 64 billion euros. And the most distinctive or the most important difference between Germany and Australia is that every hospital in Germany is a legal entity. So they are working on their own. Of course, some of them are owned by the state or the municipality. Some of them are owned by private for-profit companies. And some of them, that's something you find throughout Europe, are owned by the churches. So either Catholic or Protestant churches, they're also owners of hospitals. And so every hospital operates on its own and has to make at least a balanced result every year. Otherwise, there is a risk that they can go bankrupt. And also between the insurance agencies, there's a mild competition, not too much, because your 15.5% insurance rate is the same throughout Germany. So no matter in which of the 141 insurances you are insured, you always pay 15.5%. So automatically there's not very much competition possible. But the insurers are purchasers and the hospitals are providers. And they work on a contractual basis and do annual budget negotiations. So it's a system very much different to what you have in Australia. We use a system, we call it German DRGs. Except for mental health, we use it since 2003. Mental health, our own classification was developed and is used since last year only, so it's quite new. And the German DRG is based on Australian refined DRGs. Because we have this situation that every hospital has to write bills to the insurance companies, our system is much more differentiated than the original Australian system. And because hospitals really live or die depending on DRG payments. And every year we see something between 20 and 50 hospitals going bankrupt, and then they are either closed, turned into aged care homes, or sold to private hospital operating holdings. Not everything is covered by DRG. It's like always, even in these, you never have all-inclusive. There is something on top. And in Germany, we have some co-payments on a national level, and then we have some individual payments. And if I traveled through Australia the last 3 weeks, and I was really impressed how vast your country is, and I really believe that there are hospitals in remote locations that need block funding. In Germany, there was a discussion on remote location hospitals and whether they need extra funding to keep them alive. And then we came up with the decision that, okay, there might be hospitals that are too remote and too important to close down. In Germany, we have 2 hospitals out of 2,000 that fulfill these criteria. And what do you think the distance is that a patient has to travel until a hospital is allowed to be a remote hospital? 50 kilometers. So if the hospital is more than 50 kilometers away from the next hospital, it cannot be closed. So, you know, Germany, small country compared to Australia and 80 million people and a lot of hospitals. And outpatient care in the German hospital system is very, very small, unlike here in Australia or in other countries, because we have a lot of outpatient or clinical specialists that run outpatient practices. These co-payments, they were introduced because sometimes there are conditions in a DRG that are not predictable. For example, dialysis or blood products. In nearly every DRG, sometimes a patient can show up which is on dialysis. So if he breaks an arm, he needs surgery, but he's on dialysis. So the dialysis is not compromised in the surgery DRG, and that's why we put in these co-payments in place. Meanwhile, we have 159 co-payments. And here's an overview on our DRG system. We have nearly 1,200 DRGs in 2014, and there are 43 of them you have to negotiate individually. The rest are nationally priced or have at least a national relative weight. Then we have some same-day DRGs for same-day cases, and we have these 159 co-payments, out of which 95 have a national price in euro, and 64, again, are due to individual negotiation. So I think you can see there are some differences between Germany and Australia, and in the way we use this DRG as a funding system. Basically, you can say it is a payment system, and hospitals are very much depending. And one of the concerns when DRG were introduced, and if you look into the literature, these are concerns going all over the world. It started also in the US when they started back in 1983 using the IHPA DRGs, that quality of care will go down because DRG sets perverse incentives on shortening lengths of stay and all these discussions. You have them in Australia all the time. All over the world, the discussion is the same. Quality will go down. So in Germany, we said, okay, we need to counterbalance this, and we have to look into our quality. And there is a constant research going along with the DRGs to check if the quality of care goes down. When we talk about quality, then back in the 50s, Dr. Michael made this model of the 3 tiers of quality. You have the structural quality, the process quality, and the outcome quality. I think most of you are familiar with these dimensions. And if you look into the healthcare system, then you see, okay, in the structural quality, you have the infrastructure of the hospital, technology, skills of staff. If you don't have a theater, you cannot perform surgery. So that's infrastructure quality. Then you have process quality, and most of the things we talk today have to do with process quality. It's occurrence rate of complications, adverse events, the adherence to guidelines, to pathways. And then we have outcome quality. These are the measures that we use to look if we perform well or not, and that could be things like length of stay, ICU days, costs, of course, and also a very hard indicator for outcome or quality is mortality, because it's very easy to measure. The patient leaves the hospital alive or dead. So it's a very distinctive measure, an easy measure. And quality management is going around in circles. It never ends. Once you start quality management, then you never can stop it. And as I'm a clinician, I'm a surgeon by training, it's very much like treating a patient. First you do test and assess, then you put a diagnosis on the patient, then you plan your therapy, then you implement the therapy, and after a certain time, you do a reassessment. So it's quite similar to treating patients. And what we can do with our data is basically the first step over here. That's the only thing where we can use data. Later on, we have to go right onto the patients or the records to find out more about quality. And I'm going to show you something how we can use or use routine data in Germany. And of course, if you look into routine data, there are a lot of pros to use routine data. It's readily available. You have it stored in your databases. You have relatively low efforts for data acquisition because it's already there. And you can usually grab on standardized data sets, so you can analyze big numbers of patients with the same algorithms and very fast. The comparison is easy, and if you have a good data quality, and I was listening to some of your talks over the last days, data quality is always an issue, but if you have a good data quality, then you get a realistic picture. On the other hand, the routine data does not allow you to make the real diagnoses. It's just like a lab test. You see, okay, there is something, some pathology, and then you have to go into the details and find out what is really wrong. And not all clinical information are at hand, so then it's getting more difficult to learn more about your quality because you need the medical record and have to sit down and talk about it. And if we look into the data that are available in Germany, then on one hand, we have pretty much the same data set that you have and use for activity-based funding or DRGs, because as our system is derived from yours, it's very, very similar. We have diagnoses. What we don't have in Germany is a present on admission flag, but we have procedures, we have the DRG, length of stay data, we have other episode data like age, gender, postcode, we have the discharge information. In Germany, 07 is death, and in some hospitals we have patient-level costs. And then with introducing the DRGs, we introduced on top a mandatory quality data collection. So every hospital has mandatorily to deliver every year some quality data. That's structural information, all this information above, and then there are over 200 quality indicators that are routinely collected. Many of them you can derive from the coded data, but some of them are extra work. So we have these two data sources, and these are available all over Germany for all German hospitals. And there are various applications where we use these data. We have opened to the public portals, internet portals. You can go there and you can make hospital comparisons that use the quality reports and the ICD, OPS, DRG data. And one of the most known is the Health Navigator by the AOK, which is a German insurance company. And another one is on a non-profit website, which is hospital-driven. So hospitals and insurance companies always a bit in competition. And so once the insurance companies set up something in the internet, the hospitals also do, just to keep up the pace. And then we have programs that can be joined. It's not mandatory to go in these kind of quality programs. The QSR program is quality assurance with routine data. And it's doing a bit more than just looking into DRG data. It was initiated as a joint venture from a hospital group and the AOK insurance. And the insurance, of course, they have data on the follow-up of the patient. So QSR does also look in a 6 to 12 months follow-up for the patient. How often does he see the doctor and so on? And there's the QMIC initiative. It's a hospital-driven quality and benchmarking initiative. And then there are, of course, other things like 3M quality reporting. I think they do it throughout the world. They do this kind of reporting software, sell it. And IMR, infection management with routine data, is our portal from our institute that we use currently. We have something about 50 hospitals that routinely look into the data, and we can do benchmarking and comparisons over 200 hospitals. So these are things that are available in Germany. And I'm going to show you an example. Also, this website is in German. I try to explain you. 2 months ago, my mother called me, and she said, you know what? I've seen the doctor, and I need a knee replacement. So I need a knee prosthesis. And I said, oh, wow, okay. And then she said, which hospital is good? And I said, okay, Mom, I'm going to look for you. Then I went on this website, and what I did, I just entered the diagnosis and my personal postcode. And when I do this, up comes a list of hospitals. And I can see the name of the hospital. Then I can see the distance. Look at the distances. Where I live in Munich, okay, it's a major city. I can virtually go by foot to, or by bike to all these hospitals. But I also see the number of cases per year that they treat in this indication. And I see whether the hospital is recommended by patients or not. And I see infrastructure information, how well are they set to treat me or my mother. And I see results in quality indicators. And these little green things, these are the tree of life. It's the logo of this insurance company. And then I found a hospital. I said, oh, wow, that's good. Look at these. They have 93% recommendation by patient. But, oh, oops, they only have one tree of life. So I say, what's going on there? Then, of course, you can drill down. You can look a bit deeper. And then you see all these informations. And the hospital I was looking for, they have a circle, a minus, and a plus. That means unplanned follow-up surgery, they are only in the average of all other comparison hospitals. Surgical complications after surgery, there's a minus. They have more surgical complications than other hospitals have. And mortality, at least, there's a plus. So, but still I was thinking, is this a good place for my mother to send her? And I said, no. And then I said, okay, you know, that's only 5 kilometers away, but I tend to drive 13.8 kilometers to this hospital because they have 3 tree of life and they have a plus plus and an average. That sounds good. And in this list of hospitals nearby where I live, they are the best. So I would send my mother to this hospital rather than to this hospital. And such portals are open to the public. Everybody can look into it. GPs can look into it before they make a referral to the hospital. And so this is one way of making quality transparent. The downside of it is, I'm not quite sure what this circle means and what this plus means, and it's a bit, you know, plus obviously is good and circle is okay, but I don't know the data behind it as a patient or a GP. So then my father called me and he said, you know, I need a hip replacement. I said, okay, I'm going to look it up for you. And I thought, okay, I'm not so happy with the hospital navigator, because the hospital navigator, they only show me these circles and plus and minus. Then I went in the portal, which is driven by the hospitals, www.krankenhaus.de, Krankenhaus means hospital in German. So I went there and I said, oh, wow, look, Schreiber Clinic. I know him. He was a mate in university, and he inherited the hospital from his father, so it's a private hospital. And I said, oh, that's good, but oops, there is also something not so good. You know, all these hospitals have 3 thumbs up, which means very good, and he has a yellow thumb like this. I said, okay, what's it? If you go down on this portal, then you get a lot more information. Here in hip prosthesis, we have 3 quality indicators that are routinely measured. It's the luxation of the prosthesis. So the prosthesis goes out and you have to fiddle it in again. Surgical site infection, I think everybody knows what a surgical site infection is. And unplanned resurgery. And for these indicators, we have a national quality target. So the national quality target in Germany says, we want to have less than 5% patients having such a luxation. So 1 out of 20 is okay, but more we do not like it to have. Surgical site infections, we say, okay, it should be less than 3%. Because if you look in the literature, 3% surgical site infections is normal, and if you're above, then it's not good. And that's the national quality target. And then look at this. That's the national average of all German hospitals doing hip replacements. So the target is less than 5%, but the national average is 0.4. And in this hospital, I have 5.5% luxation, so maybe this is not a place where I want to send my father to. Also, infections. The national average on infections after hip replacement is 0.7%. And they have 1.4, so it's double the national average. Okay, it's below the national quality target, but it's double the average. So these things you can use for choosing a hospital which you think is suitable to do surgery for you. But there is a downside. You have the problem of small numbers. If you look in percentages, if you treat a small number of patients, each complication has a huge effect on the percentage. And in this example, if you treat 50 patients per year and have 1 surgical site infection, that's 2%, so you're below the national target. If you have 2 infections, that's already 4%, then you're in the red zone and you're above the national target. I'm a surgeon myself, and some of you might be clinicians and also surgeons here in the room. Everybody will agree, in 50 patients, whether you have 1, 2, or 3 surgical site infections, is absolutely within the statistical variation. So it's unpredictable. So that's a bit of a problem in using this data and say this is a good or a bad hospital. You also have to look in the total number of patients they treat. If the number is low, the indicator values as a percentage are not as helpful as they could be. Other indicators are the QSR indicators, and they, for example, sorry, it's all in German. These pictures are not available in English, but I'm going to take you through. It's about stroke. Oh, it's even here, the English word stroke. So this is our performance in stroke. And I put a hospital, we are working with them for quite a bit time, and they have, in the group older than 84 years, 36% of the patients die. The quality target is 21. The private hospital group Helios is 70.6. Our benchmarking group has 16.5, and this hospital has 36.3. So obviously, that does not look too good. So they should have a closer look into their data. There's also a bit about coding, unspecific coding, I64. We have 50% of the patients that die. But there are not so many patients, either 20 or 80, so it's easy to grab the records and look into it and look what's going on there. Do we really have a problem? Or is it only something in the data, a bit an irregularity in the data? But to find this out, you have to go into your data, into your clinical records. Here's a picture from the QMIC initiative and from the 3M. And this is what we do. We developed over the last years algorithms to decode DRG data and to detect infections out of the ICD-10 coding, and then to look closer into these infections. You can see, in this case, respiratory infections are predominant in this hospital, and then you can also look where does the infection come from. You can see that 21.5% of all patients of this hospital have any kind of infection problem, and that's pretty much the number we find in pretty much every hospital we go to. So 20%, 1 out of 5 of your patients has an infection problem. So infections are relevant. And now let's land the helicopter and let's go into a hospital and have a look what we found there. It's a hospital in North Rhine-Westphalia in Germany, and it's a Catholic hospital owned by the church. And they introduced patient-level costing, and then they were very happy to participate in the National Cost Data Collection in Germany. And then their controllers, they did some work on the data, and all of a sudden they found out, oops, there is a patient group where we make huge losses. And then they invited us to have a closer look into this data. And we found out in the outliers, so the length of stay outliers, which are normally patients you cannot treat with profit, 50% of all outliers had an infection problem. And then we went into the data and looked a bit closer. And you have all seen pictures like this, even if there's, sorry, a German title. You know, every DRG has a low trim point, an average length of stay, and a high trim point. And we say this is the profit zone of a DRG. These no pay days, we call them problem zone, because as long as your distribution in a hospital is even between profit and loss, you still can come up with a balanced result. And once the patient is an outlier, of course, you're in the loss zone of a DRG, and we made these 3 areas just to have it a bit like a traffic lighting. And looking in this hospital, before we started the project, so in the first analysis, we found out that patients with hospital-acquired infections have a lot of outliers, especially in the area of VAP. Not many patients, but many outliers. And then we looked into the cost data, and we saw, okay, for all these infections, they receive 3.3 million euros, but their spendings are 3.8 million. So they make, for these 442 patients, they have a total loss of 500,000 euros, which is not very good, because as you might remember, a German hospital has to have at least a balanced result, because this hospital, it's owned by the Catholic Church. So basically the bishop, or in the last instance the Pope, is the owner of the hospital. And they do not like loss. They do not like to bail out their hospitals. Sometimes they do it, but only if they are really convinced that the hospital has a chance to survive. Even the churches close down hospitals sometimes. But they're not happy to bail out their hospitals. And municipalities are also not happy, and very often they don't do it anymore. So €500,000, that's quite a bit. And so they ask us, what is going on there? And I said, we have to look in your data a bit closer. And then we looked into the part of the respiratory infections, and we found, oops, in the pneumology department, only 4.7% of the patients die. In these two other departments that are both internal medicine, 13 or 10% of the patients die. So this is also something, maybe they have different clinical pathways in different departments. And so we are going down and said, okay, let's get the diagnosis in this hospital. And this is done via peer reviews. I think you're all familiar with peer reviews. So you take the medical records, sit together with the doctors, and talk about the cases. And we did a review of the onset date of the infection and an assessment, did we choose the right therapy or not? And we wanted to find out whether this is just bad luck. You know, the hospital can have a population of very ill patients, and so they can't get away from this debt, and they have to compensate it via other earnings or profits. Or maybe there are areas for improvement. And when we were going into the result, the hospital has 3 sites, and then we found out that in the best hospital, 60% of the patients received the correct antibiotic therapy on day 1. This is something you might say, whoa, that's bad. And one hospital even is below 40%. I recently found a review by the Cochrane collaboration, and they reviewed over 60 studies from all over the world, and the average of correct initial antibiotic therapy in infections is 50%. So every second patient has a risk to get the wrong medication. And if he gets the wrong medication, he does not recover, and he is longer in the hospital and costs more money. We found there are a lot of things to optimize, and we did trainings for the doctors. We introduced infection consulting and introduced an ABS program, antimicrobial stewardship program. And then we told the people, okay, make it better, but we come back in 1 year and we're going to see how you perform. And after 1 year, there was still a bit of a loss in these patient groups, but in the area of MRSA, or very complicated bacteria, they make profit. In other areas, they make still a bit of loss, but compared to the year before, they realized savings of €300,000. So they did quite well. They really improved their performance by using routine data, analyzing them, going into the charts, seeing what can we do better, and by implementing the change. So they went all through the quality management cycle one time, and they are even improving even more. This is, we are still having contact with this hospital, and they are even getting better and better and better. So it's possible to use your routine data and to go into the analysis and then really to make financially substantial savings. And this hospital, if you have less length of stay in the infection patient, then your bed is empty, which is, of course, a downturn, because what do you do with the empty bed? Costs you money. They managed to acquire 120 new patients, putting in the free beds, and they even made a revenue of €500,000 with these new patients. So on the one side, they saved money in the infection patients by treating them better, and they made money by putting new patients into the free beds. Nevertheless, in Germany and in many other countries, we have this movement towards quality-adjusted reimbursement. And I remember Tony's talk yesterday. He said, well, it's so obvious. Why should we pay bad quality? So something like quality-adjusted reimbursement seems very natural. Why should we pay when the hospital does something wrong? It's so obvious, so let's bind our payment to the quality. In Germany, we have another problem. These curves show you the 3 most top expenses of the public insurances. And you can see these curves, they are quasi-linear, quasi-parallel. There is no real increase in cost. And that's drugs and outpatient treatment. And the red line is the hospital sector. It's constantly growing. So the expenses in the hospital sector, of course, the hospital costs more than maybe the treatment in the outpatient area, but the growth is much faster. And that's what worries them. And so they said, okay, we need to have quality-adjusted reimbursement. And the new government came in place last October, and they said in their white paper what they want to do over the next 4 years. We're going to have an initiative to bind payment on outcome quality. We're going to separate the good, the bad, and the ugly. It sounds very good, and it sounds very reasonable. And the insurance companies, to be really honest to you, they wanted tools to pay less, regardless how. And the hospitals on the other side, and I'm from the hospital, they always claim we have already the best quality in the world, or in our country, or wherever. And the hospital, if you look into the hospital development over the last 10 years, then you find that case mix volume is growing even faster than the costs. So this is, of course, an efficiency effect when you introduce activity-based funding or DRG. So case mix volume is growing faster than the cost growth rate. That might be an indicator for efficiency or for doing the wrong things. Internationally, these models are known as P for P, pay for performance, pay for quality. Yesterday we heard from Cassie that the never pay or never again conditions when they occur and the hospital doesn't get money. So it might be a good idea. And we were looking into this. And I have to tell you, it's very complicated and maybe it's not even a good idea. It sounds good, and it would, of course, really put a very strong incentive on best quality. On the contrary side, measuring quality is endlessly complex. Today's tools that I showed you, routine data, it's like lab testing. It's only the very first step. To take the diagnosis, you have to do individual analysis. The data quality is paramount. If your data quality is not really perfect, then you might measure the wrong things. And risk adjustment, which is very important for comparing quality between institutions, is only evidence-based available in a very few clinical entities. Then I showed you the small number, big effect problem. And this thing would bring massive bureaucracy. And it's going on, no more pros. There is very little international evidence that P for quality, payment for quality, or whatever you call it, really achieves the intended results. One thing, readmissions. We were talking about readmissions several times in this conference. In Germany, we have it already in place. If a patient comes back to the hospital within 30 days, normally the hospital is not does receive no payment anymore. So readmissions are not paid. This we already sorted out. And not every hospital-acquired condition, and this is a very clinical thing, is avoidable. If you are a high-profile surgeon and treat complex patients, and then maybe you do a hip replacement for somebody who is 100 kilos, has hypertension and diabetes. The risk for this patient to acquire a surgical site infection is 10 times higher than for a slim patient with normal blood pressure and no diabetes. So if you treat these patients, then your risk that these patients acquire an infection is higher, even if you do everything perfectly well with this patient. They can get an infection because of their comorbidity conditions. And the most important thing I'm going to show you on the next slide, I think quality adjusted payment is already existing. As I showed you, in this hospital, before they were looking in the quality of antibiotic treatment, they made a massive loss with these patients. So bad quality is unprofitable. And maybe some of you have been to the workshop on Monday. Stephen Duckett, he pointed out that the relative weight and the money which is bound to the relative weight is not the same like your profit that you make. Even if a patient has a complication and we pay for it, and he gets in a higher paid DRGs, very often these patients with infections or very high complications, they still are outliers and they still cost more. So bad quality is unprofitable already today. And then think back to the portals that I showed you, the internet portals. Bad quality, due to the enhanced transparency, has a bad marketing effect on your hospital. So they are, I think, at least for Germany, and maybe it's the same in other countries, there are enough mechanisms already in place to give strong incentives to hospitals for delivering good quality. So I don't think that quality-adjusted payment programs are really necessary because they are huge bureaucracy, and the output and the achievements on an international basis, you can look in a lot of publications on this, are comparably low. Maybe you have a higher impact, and that's what we discuss in Germany in the moment. If you do a strict control of the indication. There was an OECD report published last year, and it showed that in certain areas in Germany, it's 4 times more likely if you're over 55 that you wake up one morning with a pacemaker than in other areas in Germany. And I said, okay, maybe these people are very sick there, but it's not. You know, if you look at the comorbidity profiles of these patients, it's not. But there are 2 big hospitals in this area, and they are privately run, and they just build up big, huge cardiology cath lab units. I wouldn't say that there is a correlation, but it might be. It might be that having the cath lab drives doctors to find the patients, to put them through the cardiology unit. So because this is the case, and many people, of course, from the insurance side mainly in Germany say, a part of our case mix growth are unnecessary treatments. So I think partly this is true, partly not, but partly it may be true. So if you make a strict control of the indication, we're going to introduce a system in Germany from next January on. It's called second opinion. So if your doctor tells you you need a pacemaker, then you have the right as the patient, no, I want to see a second doctor. For example, if your GP refers you to the doctor in the hospital who is, by the way, running the big cath lab. So he might not be totally objective in assessing your indication. Then you have the right from next January on to say, no, I go to a second doctor, and it is paid by your insurance company, this second visit. I want a second opinion. That might be a good idea just to look, are some things really indicated? And we heard this also yesterday in Cassie's talk. There are these choosing wisely programs, so stay away from nonsense treatment is also maybe a very good thing on capping unnecessary growth in expenditures. Yeah, so I think routine data are a useful resource for looking into clinical conditions. You can make connections between clinical outcomes and economic results very easily. They are quasi at your fingertips. You need the in-depth analysis, but it's facilitated. It's like a funnel. You just put everything in, and out comes a smaller number of patients where you can grab the medical records and look if he did really perform well or not. And I'm quite convinced that better quality of care is a profitable endeavor. So you should seek for it. Because better quality of care leads to less complications, shorter lengths of stay, and shorter lengths of stay is better profitability in DRG or ABF funding systems. and stay away from pay for quality. Thank you very much.